All right, hi guys, I'm Kyle. I'm one of the fourth years, for those of you who don't know me, and we're going to be talking about dental emergencies today. So dental emergencies. Of course, we're not dentists, but people are going to come to the ED for just about anything. And even though at Jacobi we're lucky enough to have a dental clinic that we can send people to. What do we do? What do we do if it's 3 a.m. on Friday night and dental clinic's not going to be open? Do we call dental in? Do we not? So today I had a big when I initially put this presentation together, it was like over half an hour long, so I had to heartbreakingly cut a lot of things out. So it turned into more of dental trauma. Okay, so we're going to talk about some of the dental anatomy, dental fractures, and dental avulsion. So chipped teeth and teeth that fall out. And in the ED, we're mostly concerned about what is the management of this. Of course, we're not dentists. The sort of definitive management for any dental thing is going to be seen dental. But what needs antibiotics, what doesn't, what is there anything I should be doing in the ED, and what needs an emergent dental consult versus what can wait till tomorrow morning, what can wait for a scheduled dental appointment. So first off, we're going to go through a little bit of the anatomy. It's always important to be able to name the communicate with your consults in sort of the language that they use. So one of the sort of methods of naming teeth that classically is in a lot of our literature is this sort of numbering system. So you're assuming you have your wisdom teeth in, top right is going to be tooth number 1. It's going to go all the way across. Top left is going to be number 16. Bottom left is 17, all the way down to 32 in the bottom right. So it just goes in a big circle. If you don't use the numbering system, because some dental people don't use that either, you can just call the teeth what they are. The first on either top or bottom, first 4 are going to be the incisors, followed by the canines. You're going to have 4 premolars, and the back 4 or 6 are going to be the molars. So it's always going to sound better to say, all right, we have an LS3 fracture in the mandibular right second molar than it is to say, oh yeah, the tooth is broken on the bottom and I see red stuff in it, please help me. Okay, so just to go over the anatomy a little bit. So the tooth is divided up into 2 main parts, the crown and the root. The crown is the part that's going to be above the gum line, and that's going to be coated in enamel, the hardest substance in the body, and that should be the only visible portion of the tooth, hopefully. The interior of the tooth is made out of the pulp, which is the neurovascular supply. That's the part that we really want to protect, because any compromise of the pulp itself is can lead to infection, pulp necrosis, and they'll have to get a root canal or have their tooth taken out. We want to try to avoid that. Dentin is it's this porous connective tissue space between the pulp and the enamel, but any compromise of the dentin can compromise the pulp as well. And it's all anchored in by the periodontal ligament into the alveolar bone. So talking about dental fractures, it's divided up into LS class 1, 2, and 3, depending on which layers of the tooth are compromised. So an LS1 is just like a little chipped tooth. It's if you look at the avulsed portion, then you're only going to see more tooth underneath. It's usually pretty painless, and the only real issues are that it can kind of irritate the inside of the oral mucosa if it's like jaggedy. But otherwise, for these people, they don't require antibiotics. They don't really require any particular management in the ED. But they should be referred to a dentist, especially if it's like in the front for like aesthetic repair. LS class 2 and 3 are a little different. So in a class 2, you might see some opaque yellow or opaque red underneath the on the avulsed portion of the tooth. And this is most dental fractures in adults. LS3 is if you can see the pulp. So you're going to see red tissue, blood. If you wipe the avulsed portion with gauze, you might see something on the gauze too, some blood or some tissue. And these are painful. You're going to have pain and hot and cold sensitivity. So for these, the pulp and the dentin are exposed. So we want to be able to cover that. So based on Tintinelli, in the ED we always send these people to dental or have dental come see them. But if we're out in the community without dental immediately there, these people should have their dentin or pulp covered because you want to avoid contamination with the oral flora. So if it's LS2, Tintinelli recommends using Dentemp. So Dentemp is like this moldable putty that you can kind of just squish onto the the exposed portion. They bite down for a couple minutes, and it forms this like temporary seal on their dentin. If it's a class 3, then you're going to want to put a calcium hydroxide paste on before. So it's like this paste that you mix with something to firm it up, and then you're going to put Dentemp over that. At Jacobi, we don't have these in the ED. We have like a version of the calcium hydroxide paste that the dentists use, but it's like different. It like requires more preparation, so we always call them down. But these people should be covered with penicillin or clindamycin to cover for oral flora. So these people are someone who I would not send out. They should see a dentist like while they're in the ED. So dental avulsion, someone's playing soccer and they get hit in the face with a soccer ball, and now they have a broken smile. So for these people, so when they come in, if they haven't popped their tooth already back in the field, then you're going to want to get their tooth as soon as possible into some normal saline or some other isotonic solution. Hanks is recommended. I guess it's a solution that's made specifically for keeping teeth alive. But you can also use milk if that's what you have available. Try not to use saliva or water because those are too hypotonic and it causes the tooth to die. If you don't know where the tooth is, then you should do a chest X-ray because they might have aspirated, especially in kids or people who have altered mental status or have been drinking or something else. And sometimes, even if the tooth is the most prominent sort of traumatic feature of their presentation, always consider other facial trauma. Do a really good orbit exam, do a really good face and mouth exam, see if you need to get a CT or any other studies or if there's any airway issues. And if the tooth was on the ground, then you're going to want to give them a tetanus shot if they're not already covered. So what do you do with this random tooth that they brought in? No, we don't want to scrub it. Oh, we were just going to talk about that, Dr. Chertoff. So if the tooth is on the ground, we don't want to scrub it because you're going to take the tissue and damage the residual dental ligament. And you don't want to do that. You're just going to lightly irrigate it with normal saline and only hold it by the crown. Just like leave the tissue alone. If there's a little bit of like dirt that you just can't irrigate off, that's okay. You can still reimplant it. All right, so you've got your nice irrigated tooth. You're gonna put like a local block in because replacing it is really painful. Then you can get some normal saline, irrigate the clot out, and then you can just place the tooth in. Now, all of these people are gonna need to have their tooth splinted. The splints that we have at Jacobi are these wire splints that require preparation of the tooth and a light to like harden the glue that glues the mold to the tooth. So we can't really do that. But other sources I've been reading about talk about like other moldable splints that your ER might carry, or in a pinch you could use aluminum foil. And there's also a method of using that flexible bridge from a face mask and gluing that on too. But these people should get splinted definitely before they leave the ED. The goal is to reimplant the tooth within 2 or 3 hours if it's been as soon as possible. Because within an hour, if the tooth is left out, like the root's already going to start dying, and even if it is in a solution, then you still only have like 2 or 3 hours. And these people should also be discharged with antibiotics. If you have a pediatric case, don't put the teeth back in if they're primary teeth, baby teeth, because sometimes it can fuse the alveolar bone and can cause like jaw malformations or mess up the development of their adult teeth when they do come in. So in summary, if it's just a tiny little tooth fracture with nothing else, then they can just follow up with dental non-emergently. If you see anything that's not tooth and it's painful after a tooth fracture, then they need a dental consult because it needs to be covered up. And if the tooth fell out, you need to get that tooth in as soon as possible, and it needs to be splinted. I wouldn't wait for dental to come down to replace the tooth because time is tooth, just like time is brain, time is heart. Okay. And there. Huh? And